On behalf of the American Heart Association, I would like to welcome you to today's Implementation Science webinar, Lp(a) in Special Populations, Aortic Stenosis and Peripheral Arterial Disease. Before we get started, let's take a quick moment to go over how to use the platform for today's event. If you run into any technical issues, a simple browser refresh often resolves most problems. If that doesn't help, please check the system requirements or reach out to the Zoom webinar helpline for support. During the presentation, you're welcome to submit questions at any time using the Q&A feature on your control panel. We'll do our best to address them during the Q&A session at the end as time allows. At the close of the webinar, you'll receive a short feedback survey. We'd really appreciate your input to help us shape future Lp(a) education to better meet your needs. This session is being recorded, and we'll share the recording with all registrants via email in the coming weeks. The recommendations and opinions presented by our guest speaker may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA-ASA. The AHA-ASA does not endorse any product or device. High Lp(a) levels are genetically inherited and are a common independent risk factor for heart disease, affecting approximately 1 in 5 people worldwide. The American Heart Association launched a 3-year national initiative, the Lp(a) Discovery Project, to increase Lp(a) testing by improving processes across care settings through national education. As an enhancement to this work, the AHA launched the Lp(a) CHC Discovery Project, which seeks to identify various approaches and barriers to Lp(a) testing within CHCs and develop national education to improve knowledge and increase awareness surrounding Lp(a). Today's event will be an additional resource on our heart.org/LPA Discovery webpage, along with all of our other great LPA resources, including podcast, an FAQ clinician guide, and other enduring resources. It is my pleasure to introduce our first Lp(a) expert, Dr. Nishant Shah. Dr. Shah is a cardiovascular disease prevention specialist and assistant professor at Duke University, where he also serves as associate program director for the Cardiology Fellowship Program. He leads Duke's remote lipid monitoring program and oversees the implementation of inclisiran across the health system. His research centers on PCSK9 inhibitors, lipoprotein A, and advanced lipid therapies with ongoing involvement in multiple clinical trials. Please join me in welcoming Dr. Shah.
Well, thank you so much, Kelly. I really appreciate the kind introduction, and thank you all for joining this webinar. I'm really excited to talk about this topic. It's a topic that's that I'm very passionate about. I know, as is Dr. Bonaca and the rest of the AHA team, and so really honored to talk about the association of LPA and aortic stenosis, something we don't talk about too often, as we're so focused a lot on LPA and atherosclerotic cardiovascular disease. Go ahead and move my slides here. So these are my disclosures, but again, this topic and talk are for educational purposes only, and I have 4 learning objectives really for this short piece that I'm a part of. I'd like to discuss LPA as a marker of risk, describe the pathophysiology of LPA related to calcific aortic stenosis, describe the clinical implications of aortic stenosis and Lp(a), and then highlight future directions of research. So since I'm, talking first in line, I just want to reintroduce everybody to Lp(a). I imagine most of you guys on this call are super familiar with what Lp(a) is, but just to make sure we're all on the same page, Lp(a) is a causal independent lipid-like biomarker that is associated with cardiovascular events. It is almost entirely genetically originated. And that doesn't mean it has to just run in families per se. People can develop their own genetics of elevated Lp(a) as they are being, formed in the womb. There's several isoforms of Lp little a. So what that essentially means is that there are different particle sizes of Lpa that exist. And this becomes very relevant here as we talk about aortic stenosis. But there are smaller particles and larger particles. A lot of it is dependent on the number of kringles, which is a protein molecule, if you will, that extends off of the Lp little a particle. Levels don't necessarily vary without intervention over time. Again, you got to be mindful of the different types of lab assays that you use because different labs can measure Lpa at different levels. However, in general, we expect Lpa without any intervention to stay relatively consistent throughout time. Lpa also consists about 30 to 40% bound LDL, and standard assays that measure LDL may not be able to distinguish between Lpa, bound LDL, and free LDL. And so just to keep that in mind. And there are a lot of different pathogenic mechanisms as we're learning more and more about Lpa, which includes a combination of inflammatory mechanisms, atherogenic, as well as thrombotic. And so in terms of the distribution of elevated Lpa across gender, we know based on large cohort studies that about 20% of men and 20% of women have elevated Lp little a. But it's interesting. There's different subpopulations that can have higher frequency or higher ratios of elevated levels. So particularly in patients with familial hypercholesterolemia, we're seeing anywhere between 1 in 3 to 1 in 4 patients having elevated Lp little a. And in those with premature atherosclerotic cardiovascular disease, we're seeing somewhere between 1 in 4 and 1 in 3 as well with elevated Lp little a. There is distribution that varies across different ethnicities and races. I have here listed various ethnicities, and you can see that the mean Lp little a level is different. Now, what that means prognostically, we're still trying to figure out. So, for instance, myself, I'm South Asian. With me having an Lp little a, let's say, or my ethnicity, or if you will, or my subgroup, if we have an Lp little a that's, let's say, means around 30, what does that mean to someone else, another group that has an Lpa that means around 50? Is 30 high risk for me or not? And so we need to figure that out still. But just for you guys to know as an audience that there are differences across race and ethnicity. But the bigger question, right, the elephant in the room, and why I'm excited to speak to this, how does Lpa relate to aortic stenosis? And for context, I think we all need to appreciate that aortic valve stenosis, especially calcific aortic valve stenosis, is quite prevalent in terms of a valvular disease worldwide. 3% of the worldwide population are affected over 65 years of age. And there are currently no pharmacologic treatments that we know of that, one, are indicated to prevent the onset of or progression of calcific aortic valve stenosis, but there's also no definitive treatment outside of aortic valve replacement, whether that is transcutaneous or surgical. And we typically do that when the aortic stenosis is not only severe, but also symptomatic or leads to structural changes of the heart. There is some evidence that long-term exposure to certain risk factors like hypertension or chronic kidney disease can lead to rapid progression, if you will, of aortic stenosis severity. And Lp little a has been shown to have an independent causal association with calcific aortic valve stenosis beyond the traditional risk factors. So just like it can increase your risk of heart attack and stroke, it absolutely can increase your risk of calcific aortic valve stenosis as well. So I showed you this schematic of what Lp little a looks like, how it's got a lipid core. Has a apolipoprotein B bound to apolipoprotein A, and there's also these protein folding structures called kringles, right? Now, I say all that because many of the apolipoproteins that are on Lp little a, as well as certain molecules called oxidized phospholipids that are within the lipid core, those are very inflammatory molecules. And if you have a high concentration of Lp little a, or a lot of small particles, if you will, that can result in a lot of inflammation. And what we believe at this point is that inflammation, amongst many other things, is a key mechanism of the development of calcific aortic stenosis. And here I have a schematic of sort of all the different various inflammatory cascades that can occur as a result of elevated Lp little a, ranging from reduced fibrinolysis, increased foam cell formation. that in itself can lead to more oxidized stress and further downstream inflammatory cascades because of the increased oxidative stress that can ultimately lead to more calcification. And when you have this type of inflammation with the vessel walls, you think of plaque formation forming because you're causing injury to the vessel walls. You have a lot of cholesterol molecules and similar lipoproteins kind of building up within the vessel walls and causing a big atherogenic plaque. But on the aortic valve, when you think of inflammation, you start thinking of degeneration of the valve and more calcification that can occur, restricting the function of the valve as it tries to open and close, and hence calcific aortic stenosis. And so just like there's a genetic basis for atherosclerotic risk, there's also a genetic basis of a calcific aortic valve formation, aortic valve stenosis formation. And there's about 4 SNPs, if you will, or single nucleotide polymorphisms that we worry about when it comes to calcific aortic valve stenosis. I've listed them over here, 2 of which are originated on the LPA gene locus and the other on the IL-1F9. So 2 on chromosome 6, 2 on chromosome 2. And interestingly, most of the more common single nucleotide polymorphisms, or SNPs, are also linked to atherosclerotic cardiovascular disease. However, one in particular, the RS134150997, that's on chromosome 2, is only really focused on or tends to only be associated with calcific aortic valve stenosis. So more to learn here. I just throw this out there to let you all know that there is a genetic basis behind this as well. Now, some of the best data on this in terms of clinical outcomes comes from a sub-study of the Astronomer trial. Here in this particular study, about 200 and so patients with mild or moderate aortic stenosis at baseline were assessed over time to see if those that had high tertiles of Lp(a) or high tertiles of oxidized phospholipids bound to ApoB. Now, I mentioned, if you remember from my schematic, these oxidized phospholipids are also on the LPA molecule. Did those patients have an independent association with rapid progression of aortic stenosis or not? And aortic stenosis event-free survival, if you will. And so a lot of data on this slide. And so I focus everybody to the panels on the left. And what you can see here is that amongst those that had higher tertiles of Lp(a), as well as higher tertiles of oxidized phospholipid bound to ApoB, those folks, compared to those within the lower tertiles or lower levels of LPA, no oxidized phospholipid, they had more rapid progression. So higher oxidized phospholipid concentration, higher LPA concentration led to a higher or more rapid progression of aortic stenosis, measured here by your peak velocity. And then we also looked at in the study, they also looked at differences by age. And what you can see here, in those that are under 57 years of age, or those greater than 57, which was essentially the median age across the study, those that were, above the age of 57 with high tertiles of Lp(a) and oxidized phospholipids certainly had higher progression, independent, more so in the higher tertile compared to lower tertile. But if you look at those that are under 57, those in the highest tertile of Lp(a) and oxidized phospholipid had a much faster progression than those in the lower tertile under 57 years of age. So pretty much the bottom line that to take out of that is that if you have high levels of Lp(a) or high levels of oxidized phospholipid, something that we're not routinely checking in clinical practice, but we are at Lp(a), you're under the age of 57 and already have a diagnosis of aortic stenosis, younger people will tend to progress faster. And so interesting observation to note. And then they also did a multivariable regression analysis and found that both Lp(a) and oxidized phospholipids bound to ApoB were independent predictors of aortic valve stenosis progression. And it was much more profound in those that were under 57 years of age with higher levels of Lp(a). Here's more data just to kind of showcase what we're looking at here. So in the overall cohort, you see those in the higher tertiles of Lp(a) and oxidized phospholipids had a higher rate of events from an aortic valve standpoint. So this is looking at a composite of aortic valve replacement and or cardiac death. And then look at those that are under 57 years of age, similar trends. And so important to know, especially when you have a young patient in clinic that already has a diagnosis of aortic stenosis, may be important to understand what the Lp(a) is in that patient. Then there's been some meta-analysis kind of trying to bring together the totality of the data. And then two of the SNPs have been found in this particular meta-analysis to be quite significantly associated with aortic stenosis development and progression. Both the RS104-55872 and RS379-8220. Both of these were found on chromosome 6, if you remember from the initial table that I sent. Those were very strongly associated across multiple different studies. And in general, those with calcific aortic stenosis had higher LPA levels by 22.6 nanomoles per liter. And so, in general, elevated LPA was associated with faster peak velocity rate across that aortic valve by almost 0.1 meters per second per year. So that is in aortic valve terms, quite significant. This doesn't extend to just native valves. This was a small study done looking at the impact of elevated Lp(a) in bioprosthetic aortic valves. And here they compared those with an Lp(a) defined as greater than equal to 30 milligrams per deciliter to under 30 milligrams per deciliter. And they found that those with an Lp(a) on average greater than or equal to 30 milligrams per deciliter had a higher probability of valve degeneration of a bioprosthetic valve compared to those with LPAs that were less. The median LPA in this cohort was about 50 milligrams per deciliter in those with degenerative valves, and those with, they were compared to a group with a median LPA of about 15.6 or so. So again, you have native valve progression of calcific aortic stenosis that's being observed in patients with elevated Lp(a). And now we also are having signals that elevated Lp(a) can lead to more rapid degeneration in bioprosthetic aortic valves as well. So what are the current screening recommendations for elevated Lp(a), right? We think about it a lot with atherosclerotic cardiovascular disease, but now we're starting to see data emerge about its impact in calcific aortic stenosis. And so the 2018 ACC-AHA cholesterol guidelines identify Lp(a) as a risk enhancer. So if you have somebody in that intermediate risk group or even borderline, it's suggested to evaluate various risk enhancers, LPA being one biomarker that is suggested to be a risk enhancer. And in those that have levels that are greater than or equal to 50 milligrams per deciliter or higher, to definitely consider, aggressive preventative therapies. The European guidelines, however, are a little bit more generous and probably recommend what most of us in preventive cardiology already do, and that is at least a one-time screening of Lp(a) in a lifetime to really identify those that have extremely elevated levels, to identify elevated levels of risk earlier rather than later. But the truth of the matter is that we are not testing Lp(a) enough. This is a study that we did across the US in about 600,000 patients. And we found that Lp(a) testing rates were as low as 0.4%, despite all of the data that's out there. Now, this is looking specifically at patients with atherosclerotic cardiovascular disease. So patients who have already established atherosclerosis, not necessarily aortic stenosis. But I think the idea is very clear. In a place where we have a lot of data of LPA associated with atherosclerotic disease, we're just not seeing enough testing, despite it being a guide to being more aggressive with cholesterol-lowering treatment, for instance. We also found disparities in that females and older individuals and underrepresented minorities were less likely to be tested. And then those that did have a test were likely to be initiated on lipid-lowering therapy, and those that were tested and had elevated levels were more likely to have non-statin therapies added on to statin therapies. And so, a lot can be taken out of that. It could be that those that are testing for LPA tend to be more aggressive if elevated levels come back and are more likely to be putting patients on more combination cholesterol lowering therapy. But regardless, I think the data shows that the testing rates are quite low, and our hope, especially through initiatives like the Lp(a) Discovery Project, that we can help spread awareness and help increase testing rates in general, as there are drugs in clinical trials targeting Lp(a) right now. So just a little bit of insight on various therapies, cholesterol-lowering therapies in particular, and their impact on Lp(a). Statins don't seem to really have too much of an effect, and in fact, some studies have suggested that it can actually increase the Lp(a). There's been various data on this, but there is data to suggest, or a signal rather, that it can increase LPA slightly, but that slight increase in Lp(a) compared to the benefit that you're going to get from lowering the LDL cholesterol in these high-risk patients actually favors the benefit. And so, we typically recommend, statins in general for all patients at high atherosclerotic cardiovascular risk. In terms of ezetimibe, doesn't really have an effect. Niacin can modestly drop Lp(a) levels. However, to date, there's not been any large randomized clinical trial that has shown a benefit from a cardiovascular outcome standpoint with the use of niacin. However, there's not been any large randomized clinical trial either looking at niacin in Lp(a) elevated patients alone. PCSK9 inhibitors can also modestly reduce Lp(a). We've seen that across two major monoclonal antibody PCSK9 inhibitor trials in FOURIER and Odyssey outcomes. So can inclisiran, which is an siRNA-based PCSK9 inhibitor that can also drop Lp(a) levels up to 20%. Mipomersen, we don't really see much here in the US, but has a modest reduction. And then in the CETP inhibitors, we're seeing a comeback of those, especially with a lot of promising data that is being shown with obicetrapib. That can drop LPA quite significantly, and obicetrapib in particular, up to 50 to 60%. So that's pretty interesting. And then we have antisense oligonucleotide-based therapies and siRNA-based therapies targeting Lp(a) in phase 3 clinical trials right now. And you can see anywhere between a 80 to 95 to 98% decrease in the level of Lp(a) with these therapies. And so that is going to be very interesting to see what the outcome studies of these therapies are. But again, for the group to know is that there are therapies targeting Lp(a) in clinical trials now. I want to point out sort of this exploratory analysis from FOURIER on aortic stenosis events, which aortic stenosis events in this sort post hoc analysis, if you will, of FOURIER, was defined as either new or worsening aortic stenosis or an aortic valve replacement. And, they found that patients with elevated LPA were more likely to have aortic stenosis events compared to, the counterparts without elevated Lp(a). And in terms of AVR, aortic valve replacement, elevated LPA seemed to correlate the strongest with future aortic valve replacement. And in those that were on evolocumab, which is what the drug that was tested in the FOURIER trial compared to placebo, those on the monoclonal antibody PCSK9 inhibitor had less aortic stenosis events than placebo. And so, it's an exploratory analysis, so hard to make very concrete conclusions, but suggested that those that were on evolocumab that had an aortic stenosis tend to do better in terms of aortic stenosis events compared to placebo. Now, could that be because there is a modest reduction in Lp(a) with the PCSK9 inhibitors? Hard to know. This was an observational study, so hard to make, again, strong conclusions, but goes to show that there may be something in this space in terms of trying to prevent the progression of calcific aortic stenosis with LPA being a therapeutic target. And so more data is absolutely needed to really understand this relationship. And people really believe in targeting Lp(a) because there are several molecules in earlier phase clinical trials compared to the antisense oligo and the siRNA that I showed you earlier. So you have zerlasiran, you have lepodisiran, and you have muvalaplin. All of these are therapies that are currently in clinical trials and have pretty promising Lpa reduction. And as I mentioned, we certainly need more data in aortic stenosis in particular. And so there are randomized clinical trials that are going to look at the effect of not only LPA directed therapies on calcific aortic stenosis or calcific aortic valve disease in general, but also looking at the effect of PCSK9 inhibitors in the role of calcific aortic valve disease. And so clinically, what does this all mean? So to test for LPA, to stratify ASCVD risk, that is generally the recommendation. If you have a patient, you want to know what the risk of cardiovascular events are, then testing for LPA will be helpful. And it's also important to consider in patients who have been identified to have aortic stenosis, especially if they're young. So if you test for Lp(a) and an Lp(a) level comes back elevated, what do you do? What do you do today? Well, in general, what we recommend in most prevention circles is to lower the LDL as low as possible to really modify the LDL or the ASCVD risk. Consider aspirin therapy if the bleeding risk is low. There actually has been some data to support the use of aspirin therapy in patients with ASCVD who have elevated Lp(a). And then modify what you can, right? Hypertension, obesity, diabetes, good lifestyle. Really be aggressive with those cardiovascular risk factors. Don't forget to cascade screen all first-degree relatives. So parents, siblings, adult children, make sure that, if you identify someone with an elevated LPA, know that their first-degree relatives may also have elevated levels because of the genetic link. So please make sure to find a way to get those tested. And in those that have identified with aortic stenosis, certainly there are clear echo guidelines for routine imaging surveillance and monitoring for symptoms. So definitely make sure that you do that instead, in addition to just testing for LPA if you feel that you don't quite understand the mechanism of aortic stenosis in that patient. But don't forget that routine imaging is important to make sure that they have the best outcome with their aortic stenosis. And then, of course, there's several clinical trials, as I mentioned, a lot of interest in LPA as a therapeutic target. So something to consider for patients who are interested. So with that, I'll conclude my segment. I believe it is important to test for LPA as frequently as you can in patients, because management strategies do exist today. LPA has been linked to progression of calcified aortic stenosis and observed to have an association with degenerative bioprosthetic valves across the aortic valve as well. So important to keep that in mind. There's a lot of different mechanisms on how LPA leads to calcification that revolve around inflammatory pathways. There are clinical trials exploring the therapeutic impact of calcific aortic stenosis with therapies that modify LPA, currently in clinical trials. But we need more research to better understand Lp(a)'s effect beyond just atherosclerotic vascular disease, because LPA is coming to light with so many different impacts across our body. But out of all of these conclusions, the biggest takeaway I think right now is, strongly consider testing for Lp(a) at least once in a lifetime across your patients. With that, I will conclude my segment, and I will go ahead and pass the baton to one of our expert cardiologists that I'm honored to introduce. I'm in a good, lucky, and privileged position to introduce Dr. Mark Bonaca, who is a cardiologist and a vascular medicine specialist. He serves as an executive director of the Colorado Prevention Center and professor of medicine at the University of Colorado Anschutz Medical Center. Dr. Bonaca has led major clinical trials in PAD, including both Voyager and STRIDE, and his research focuses on improving outcomes in patients with vascular disease. And so with that, I'll go ahead and pass the baton. Thank you all so much.
Well, thank you so much. It's wonderful to have an opportunity to join this session. That was a beautiful presentation, an orientation to LPA and some of the broader approaches, as well as the development spectrum. And so I'm not gonna repeat all of what's been presented, but I want to talk a little bit in this sort of context of implementation around one of the focuses in our center and where I believe there's a lot of risk, and that's in patients with peripheral artery disease. If you go to the next slide. Those are my disclosures. And next slide. Okay, so I thought this is a real patient of mine, actually, who is a 50-year-old gentleman who really is like the picture of health. I live in Colorado. We're one of the healthier states, if you will. And this gentleman is fit, healthy, and he presented with acute right leg pain with an acute thrombotic occlusion of his superficial femoral artery. And you can see when he presented, he had an LDL of 148. You can see his blood pressure and A1C, non-smoker, BMI of 25, athletic. And so, unusual presentation. He was treated with aspirin, clopidogrel, high-intensity statin. And as is often the case in the PAD world, there's a thrombophilia workup to try to figure out either why someone had a thrombotic occlusion of an artery or a graft. Go to the next slide. So I want to use this case as a context to talk about peripheral artery disease. And, we talked, you heard in the prior presentation about ASCVD, but I do want to point out that the manifestations of these diseases are quite different and how people experience them, but also the risk factors. And, while it is a common underlying biology of plaque, how the risk factors are alias for risk and the outcomes differ between these beds. And so we're going to focus on the 230 million people that have peripheral artery disease here in the lower left. If you go to the next slide. Now, PAD is often considered rare, I think, or less of a focus in ASCVD. We talk a lot about coronary disease and stroke, but it turns out that not only is there a growing pandemic of disease, but if you screen people, maybe in the partners registry in the bottom bar here, screen people who are over the age of 55 with a history of smoking or diabetes, or over the age of 75, almost 1 in 3 have PAD. And so it is vastly under-recognized, but quite prevalent. Next slide. We think about patients with peripheral artery disease because of their risk of cardiovascular events, and they are very high risk. But when we think about them more broadly, the dominant morbidity is in their lower extremities or the legs. And whether you look at registries like the figure on the left or trials and the figure on the right, what you can see is they are very high risk of MI and stroke, actually higher risk than patients who have coronary disease. But the dominant morbidity is either amputation, acute limb ischemia, where the risk is as high or higher than MI or stroke. And the majority may need a procedure to improve perfusion to their legs, either due to debilitating symptoms or to prevent tissue loss. So if you go to the next slide. We know that patients with PAD have multiple axes, orthogonal axes of risk. And so there isn't just one way to reduce risk, but we start with a foundation of diet and exercise. We know that there is clear thrombotic risk, like the case I presented to you. Smoking and diabetes are the strongest risk factors. And so those are areas of risk. There's inflammation, and then lipid risk. And you can see from Mendelian randomization genetic studies that both LDL and LPA are independently associated with the development of PAD and PAD outcomes. Go to the next slide. These are a few data that support that. These are observational data, not genetic data, but this is the EPIC NORFOLK cohort, which looked at quartiles of LPA and the incident of PAD and the hazard ratio. And you can see as you get to higher levels of LPA, it is independently associated with risk. And importantly, it's independent of LDL cholesterol, although the two are related. Go to the next slide. Now, it's not just incident PAD, but actually when you look at angiograms and you look at the complexity of disease, here using the task criteria, LPA is associated with more severe manifestation of PAD in those that have it. So they have worse disease than people who have a lower LPA, even after adjusting for other risk factors. Next slide. Now, in patients with PAD, along with their worse anatomic burden of disease, you can see that they're at higher risk of major adverse limb events as well. So high risk of incident PAD, worse disease angiographically, and now higher outcome or higher risk of outcomes. And actually, when you look at the hazard for major adverse limb events, it is as higher than that for major adverse cardiovascular events. So while much of the focus in development has been on reducing MACE, major adverse limb event risk is even more closely tied to lipoprotein(a). Go to the next slide. These are data from the FOURIER trial, as you heard from the prior presentation. And what they show you is what I stated previously, that patients who have peripheral artery disease are at higher risk of MACE than people who've had a prior MI or a stroke. And if you go to the next slide, this is even higher in patients who have what's called polyvascular disease. So patients that have both coronary and peripheral artery disease. And so they are at extremely high risk. And polyvascular disease is also associated with lipoprotein(a). Next slide. Okay, so, I saw this patient in follow-up. I didn't see him when he initially came in. He came in 2 years after his initial event. I told you how he was managed. And this is a true story. Now he, I think, was 52 years old and came in with angina after mountain biking and had a non-ST elevation MI. He had a pretty severe coronary disease. You can see on the right, multivessel disease, and required coronary artery bypass grafting surgery. At the time, his LDL was 63. His A1C was less than 5%. His BMI is 25. And he said to me, I'm 52 years old. I'm doing everything I can do. And like I eat salmon every day. He literally said that. And I've had this clot in my leg and I have blockages in my coronaries. What's causing this? And as I mentioned, his hypercoagulability workup was negative. So go to the next slide. Oops. Okay, so a lipoprotein(a). You heard about it, and I'm not going to rehash all of what was elegantly discussed in the prior discussion. But when you look here in large populations, I showed you EPIC NORFOLK. Here's a more modern population from the Copenhagen General Population Study. When you look at LPA, it is associated with peripheral artery disease and abdominal aortic aneurysmal disease, and in patients with PAD, higher risk of major adverse limb events. And you can see the absolute risks associated in a patient who has advanced age and smoking. If you go to the next slide. And another large study, again, showing in patients from the UK Biobank, almost 500,000 people here, showing that in patients who have PAD who progress to male, as well as carotid disease, there's a clear association with LPA level. And you can see on the right, on the bottom two graphs, I think it's quite clear that even at an LPA that is relatively low relative to where some of the trials are including patients, there's a clear increase in risk for incident PAD in panel A, and then the total adjusted in panel B. So multiple cohorts that have shown clearly that LPA is a risk factor for PAD and for major adverse limb events. If you go to the next slide. So we checked LPA in this individual. As I mentioned, we were working hard to try to reduce risk, and you can see his LPA was 129 milligrams per deciliter, so quite high. I check frequently in my patients with peripheral vascular disease and polyvascular disease. It's frequently elevated, and certainly was in this gentleman. Go to the next slide. What does that mean for him? Well, when we look at some of the population-based studies, here's one looking at outcomes. So I showed you male earlier, and here in the highest tertile, which was greater than 50 milligrams per deciliter in this cohort, you can see there was a much higher risk of amputation. And it does also associate with worse outcomes after CABG and MI. Next slide. In addition, we've had several studies look at outcomes after revascularization. Here at a relatively low cut point, so if you look at just 25 nanomoles per liter, patients who have a modest elevation in LPA have worse outcomes of revascularization. This was actually directly related to my patient SN, who had a marked elevation, had a revascularization. Next slide. And a similar analysis here at 30 milligrams per deciliter showing the same, that after revascularization, there are worse outcomes in patients with elevated lipoprotein little a. Next slide. And here a similar analysis on the left side. You can see the histogram of LPA levels are not normally distributed, elevated in about 20% of the population, but more frequently elevated in patients with PAD. And even at a relatively low cut point, you can see quite a clear difference in outcomes, including revasc. Next slide. And there are a summary of the different cut points. And what I would point out is that there have been Mendelian randomization studies looking at how much you need to lower LPA to provide a benefit. And that's informed some of the current development programs. And what I'd point out is that it is largely in healthy individuals over a lifetime. But in patients who have prevalent vascular disease, as we saw in the Copenhagen cohort, lower levels of LPA may also be driving risk. And so in all of these analyses, you can see that at a relatively low cut point of LPA, there's still a heightened risk of major adverse limb events and peripheral revascularization. Next slide. Okay, so how to manage, you heard some of this in the previous population. I think that the take home, or the most important, is to check it. This is an area where we've built a lot of experience in our center, where our vascular surgeons are referring patients, they're measuring it and then referring patients for management. They recognize that this is the smoking gun, and a lot of those patients that have recurrent events and unclear what's driving their risk. Their LDLs appear to be well managed, they don't have diabetes. We often find LPA as a high risk. So I agree with the prior presentation. Everyone should have it checked once in a lifetime, but certainly for these high-risk vascular patients, we find that you identify a lot of participants. And so then what do you do about it? Well, in him, he had an LDL of 60. You heard in the prior presentation, we don't have prospective results from LPA lowering trials yet, but we could push LDL lower. And based on the data from the PCSK9 inhibitor trials and a modest reduction in LPA, we chose to add a PCSK9 inhibitor and to push them to even lower targets. There are some data that suggests that there may be effect modification even for the benefit of PCSK9 inhibitors, with greater benefit in those who have a high LPA. And so we did that. There's also the potential for apheresis, which is actually to sort of clean the blood, if you will, of the LPA. And that was an option we discussed. We have a number of patients on that in our center. Next slide. These are the data I mentioned from 2 PCSK9 inhibitor trials, FOURIER on the left, Odyssey on the right. In the top 2 boxes, you see MACE, and in the bottom, major adverse limb events, both showing important reductions, both for MACE and male. And this has not been universally shown for lipid-lowering agents. Because of the strength of the data and his elevated LPA, we chose to add a PCSK9 inhibitor. Next slide. Now, in FOURIER, we did note that the association of evolocumab in male, or at least achieved LDL at 1 month after randomization. There's a linear relationship down to very low levels of LDL. But in Odyssey on the right, there is even a hint of effect modification. And so by quartile of LPA from 1 to 4, the higher your LPA, the greater benefit was achieved for male for alirocumab, despite the same lowering of LDL. And so it may be that LPA is identifying vulnerable plaque and patients that benefit from even greater LDL lowering. It may also be that some of the LPA lowering is contributing to the greater benefit. But certainly in a patient, like my patient SN, who is in the 4th quartile here, we would expect a greater benefit of a PCSK9 inhibitor, both from lowering the LDL and potentially from the LPA. Next slide. And here you can see, again, the same data looking at the benefit of alirocumab based on different cut points of LPA, showing benefit and, showing that there's benefit over time. particularly on the right side of the slide where patients had an LPA that was above 30 milligrams per deciliter, which again is not a very high cut point in the population. Next slide. So, this was my treatment approach to our patients. Certainly LPA appeared to be the smoking gun. And so we pushed LDL lower. We added a PCSK9 inhibitor. We talked about apheresis. But as you heard in the prior discussion, there's much more than that. We talked about healthy diet and lifestyle, cascade screening. We talked about, as you can see on the upper right, we talked about research and engaging in a randomized clinical trial. We do believe there may be a prothrombotic effect of LPA. And so this patient was on aspirin monotherapy, and given the data from Voyager and Compass, we felt that he may benefit from a more potent antithrombotic strategy. It's already indicated, but this seemed to indicate potentially higher risk and potentially more favorable benefit risk. So we added rivaroxaban. He knows he should never smoke. And we reinforced other preventive measures that would reduce his risk of developing diabetes. And so I think one of the take homes from a comprehensive, this is a vascular integrated clinic, is that LPA isn't just one thing. It's a marker of risk, it's a target, but it also has impacts for the family and a myriad of other decisions that we make for our patients. Next slide. Okay, so I totally agree with the prior presentation that everyone should have an LPA check once in a lifetime. Certainly that's what is endorsed in Europe, and I think more recent guidelines in the US. It's not universally covered by insurance, but we do push to check it in an institution or in a setting where you may need to be more selective. Certainly in patients like this who are 50 years old and develop symptomatic PAD, you should absolutely check it. You heard about aortic stenosis in the prior presentation. I think aortic aneurysms another place where you would think about it. There are people who have this malignant vascular phenotype, polyvascular disease, or what has been described as metastatic atherosclerosis, those that have had adverse limb events. This gentleman had, an MI despite being on good medical therapy, recurrent events, as I mentioned. When the other risk factors all look well controlled, you should think about LPA. And when there's progression despite doing what you think should work, those are all flags, I think, for elevated LPA. And so if you're not able to or not universally checking in everyone once in a lifetime, I think these are cases where absolutely you should think about LPA as a risk factor that you can measure, understand what's driving risk, and then target multiple areas to intensify medical therapy. Next slide. So in this case, as I mentioned, after we measured LPA, we had a clear uncontrolled risk factor. And I actually think this gave him a lot of peace of mind, because I think he was blaming himself for what he was doing wrong with his diet or whatever. We discussed that this is a genetic condition, the risk we talked about, and the importance of family screening. We drove his LDL to 10 with a PCSK9 inhibitor. We discussed plasmapheresis, and he's on the list for an upcoming randomized clinical trial. We also added rivaroxaban, as I mentioned. Next slide. So, be happy to entertain any questions and discussion for both of the talks, obviously with an excellent prior talk. And I'll just say that I think this is an opportunity, as we consider implementation, to reach out to communities that may be less familiar about lipids and lipid risk. Here, I've worked very closely with our vascular surgeons and our endovascular practitioners. They are frequently looking for a reason why patients progress or have a failed intervention, trying to understand whether it's a thrombotic issue or other things. And LPA now has been firmly integrated into our program, where we routinely check in patients who have symptomatic vascular disease, and has been an opportunity for multidisciplinary care and risk factor management. Thank you.
Thank you both for your wonderful presentation. The content you shared was impactful to clinical care. We will now begin the Q&A session. As a reminder for our audience, please submit questions for our presenters through the Q&A feature on your control panel. Our first question is for Dr. Shah. From a health system perspective, in the context of cardiovascular patients, is Lp(a) testing incorporated into hospital admission order sets, or is it more commonly being used as part of routine outpatient screening in clinical practice?
Yeah, that's a great question. And I think to Dr. Bonaca's point as well earlier, is that we need to create, models that are scalable to incorporate more LPA testing in general, because I think both of us and many of our colleagues in the preventive community really believe in a wide scale testing. So, I think I've seen institutions do different things. I've not seen as many institutions integrated within admission order sets. Some institutions that I have seen that integrate it, and it's not many, they'll have like an option to click it. So you don't have to click it if you don't want to when you're going through like an EMR and putting in an order. But I've not seen many do it routinely. It's kind of case by case basis. And I think that is very similar to what most outpatient practices are like, because someone may have already had an LPA test before, and knowing another one may not necessarily change your management unless they've been put on a therapy that somehow lowers the Lp(a). And so I think we need to still develop what are cost-effective models to routinely integrate LPA testing within practice. Currently, it's very much case by case. I can speak to my institution where over the last several years, there's been more of a culture shift where we've had more people talking about Lp(a). Our prevention group, the one that I work in, we've really boosted the message of testing LPA in everybody. And now we're seeing sort of everyone, including our primary care docs and others, start testing it more. And so I think a lot of it comes down to education. A lot of it comes down to pattern recognition, understanding who probably would benefit from having a test and who not. A lot of it extends to understanding what the cost of the test would be, not only at your health system, but others, and trying to make it so it's still cost effective to the patient. So combination, but to answer your question directly, we've seen it more in routine outpatient practice. Very rare, not rarely, but seldom we'll go ahead and also do it in patient, especially in some MIs that come in that are very young, or peripheral events that are very young strokes. So we'll also see that on the inpatient side too, but predominantly it's mostly outpatient.
Thank you, Dr. Shah. The second question is going to be for Dr. Bonaca. How can clinicians integrate Lp(a) management into comprehensive care plans for PAD patients?
Great question. The first part of that is identifying PAD, and it is under-recognized. And so I think the first answer to that question is making sure that you have a system and clinicians that are really looking for people with functional impairment or other signs of peripheral artery disease and identify it. I think the second piece of it is that the care patterns for peripheral artery disease are much more variable than for coronary disease in most health systems. So it may be that these patients are being seen in primary care and then referred to vascular interventionalists when something's needed, a surgeon or interventional radiologist, interventional cardiologist, whomever. And so unless you embed this sort of concept of risk and LPA more broadly than in sort of one practitioner group, then you miss it. And so we've been able to build this into some of the interventional pathways for patients either getting endovascular revascularization or surgical revascularization. It's just a standard sort of checkbox in care. You heard about that from Dr. Shah too, in sort of acute coronary syndrome patients. But here, it is a standard to check it in patients either prior to the procedure or in their first follow-up visit, and then they refer. One of the things that you have to consider is that not everyone knows how or wants to deal with an elevated level, right? I mean, there's a fair amount of patient education. You have to talk about options, there's cascade screening. And so, part and parcel of asking people to test is providing some resources for them or a referral pathway to deal with the result when it comes back. And so we've done that through our integrated vascular care team, where if it's elevated, they don't need to worry about, if you're a vascular surgeon, you don't want to manage it. They just get a simple referral. We take care of it in our multidisciplinary clinic. So I think awareness of PAD, building testing into the care pathways, and then having an easy answer for what to do with an elevated result so it doesn't become a headache.
Thank you. Our next question is going to be for Dr. Shah. Should Lp(a) testing be part of routine evaluation for patients with mild or moderate aortic stenosis?
No, that's a great question. I can give you my opinion. My opinion would be yes, it should. And I think my opinion is even stronger if that patient is younger than what you would typically expect for aortic stenosis. Now, for generations, we have known that aortic valve stenosis is sort of a disease of age, where older people tend to develop aortic stenosis because of just calcification that can occur with age and based on a variety of factors. Some may have more calcification than others. However, now that we potentially have a target to understand why people have developed aortic stenosis, and also just understanding their overall marker of atherosclerotic risk, I think it makes a ton of sense if you have a patient with aortic stenosis to test for Lp(a). But so I would say yes, and I think where the data currently is, I think a more universal approach would be to consider it strongly, especially because there may be not only a mechanism of why, but more than anything, if let's say the Lp(a) is separate from the aortic stenosis, at least you know what their atherosclerotic risk is as well.
Thank you. One more for you, Dr. Shah. What is the preventative plan for someone who has high Lp(a) over 200 but has not had an event?
That's an excellent question. And that's oftentimes a patient we see in clinic a lot. And nowadays, the patients are reading about Lp(a) on their own, and they're coming in to get tested. They're asking their providers to get tested. So here's what I do for that patient. If they have not had an event, but they have an Lp(a) that's elevated, especially that high. For me, I define elevated as greater than 75 nanomoles per liter or greater than at 30 milligrams per deciliter. I actually start them on lipid-lowering therapy, even if they've not had an event. To me, an elevated Lp(a) is kind of like a coronary artery calcium score. It's a marker of risk. And so I drive their LDL down as low as I can. For me, my personal goal for that patient is at least less than 70, even if they've not had an event. And I try to do that with statin therapy. Initially, just because it's readily accessible. I try to also add ezetimibe, depending on how high their LDL is. I go down the cascade screening route. Then I try to identify, do they have siblings? Do they have parents that are alive? Do they have adult children? To make sure that those folks are also tested. I look to see if there's anything else that I can modify, their blood pressure, their weight. If they have diabetes, their diabetes, do they smoke? Or not, So I try to modify that. I try to give them good, heart healthy lifestyle tips too. I don't just say go diet and exercise, but make sure you are truly hitting 150 minutes of moderate intensity activity in a week or 75 minutes of vigorous exercise a week. You truly are eating an extremely healthy diet. Does it have Mediterranean elements? Is it low carb? And so I push all of that stuff. And then I also try to risk stratify them more. Maybe I'll go ahead, I'll have a lower threshold, get a calcium score in that patient just to see, have they actually mounted plaque or not? Because if they have, then I may have an easier time to getting things like a PCSK9 inhibitor or other therapies if they ultimately prove to be intolerant to statins.
Okay, thank you, Dr. Shah. I think we're at time, so I'll go ahead and wrap up for us. Thank you to our speakers, both Dr. Bonaca and Dr. Shah, for the excellent discussion, and to our audience for your engagement today. We encourage you to explore our Lp(a) patient education resources at www.heart.org/LPA. Forget what the guidelines, customers. New Lp(a) elements such as value, unit, and treatment plan are now available in the stroke and coronary artery disease modules. When you exit the webinar, a brief feedback survey will appear in your browser. Your input is greatly appreciated and helps us tailor future Lp(a) education to your needs. Finally, today's session was recorded, and all registrants will receive an email with access to the recording in the coming weeks. Thank you again for attending today's webinar. We hope to see you at future LP little a discovery events. Have a nice day.